For those of you who don't know me, my name is Christopher Stone, and I'm the Policy and Government Relations Manager at Suicide Prevention Australia. I'd like to start by acknowledging the traditional owners of country across the many different places in Australia that we're all joining this webinar from. We pay our respects to their elders, past, present, and emerging. I would also like to acknowledge all those with lived and living experience of suicide, all those impacted by it, and the lives lost to suicide. I'm really thrilled to welcome you all to this particular webinar put on collaboration with the Australian Institute for Health and Welfare, the AIHW. And by the way, I should say that it took me 2 years in the community sector before I could say that acronym without mixing up the letters or stumbling over it. I can say it easily now, AIHW, 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 but that took work. And that work was worth it because of the information that the institution provides, and in particular, the information in the National Suicide and Self-Harm Monitoring System that's the focus of these webinars. Like I think many of you, the National Suicide and Self-Harm Monitoring System is a key resource for me and one I use very frequently. I realised quite how frequently I used it the other day when I was looking it up yet again in my browser. And you know how web browsers learn the web pages you go onto most frequently? Well, I realized that I only needed to type the letters A and I, and it auto-completed the full address of the National Suicide and Self-Harm Monitoring System homepage. And I think the reason why I'm on that web page quite so frequently is that at Suicide Prevention Australia, we use the data there for a bunch of different things. Just to give one example, if we're meeting with a politician for the first time, we give them a briefing pack on suicide prevention. And one of the pieces of information in it is the number of deaths in their local community. And that's a powerful and persuasive piece of information. It shows how suicide is impacting the community they represent and shows that no matter what their priorities or their portfolios, this is an issue they need to treat seriously. And that's just one way we use this data to persuade government to act in ways that will save lives. And persuading government is just one of many purposes we can use this data for. So it's something that we need to keep in mind as we're talking about these numbers, is that the numbers are, of course, more than just numbers. Every death is a tragedy. Every attempt is a person in deep distress. And both deaths and attempts go beyond the individual and affect all their friends and loved ones. And that's what makes these numbers so important, because the insights we can gain from past tragedies can help us avoid tragedies in future. And a key part of that is the research and modelling commissioned through the monitoring system, which is the focus of today's webinar. So this is research that uses the data we have to draw out key insights that can help us save lives. So I'm really looking forward to hearing more about research and modelling. Before we dive into this, I just need to make a few housekeeping notes. So firstly, remember that there will be an opportunity for questions to be answered at the end. So please ask your questions in the question and answer bar and throughout the presentations so that these can be answered at the end. Please remember when you're putting in those questions to utilise safe and respectful language and restrict questions to the topic and presentations for today. If, by the way, you feel that your question is not answered, please email Suicide Prevention Australia and we'll endeavour to answer the question. And finally, and very importantly, if you find anything in this webinar distressing, please reach out to a trusted friend, a colleague, or one of the support numbers we'll list throughout the webinar if you feel you need additional support. It's now my pleasure to introduce our speakers, Chris Killick-Moran and Rosalind Morland from the Suicide and Self-Harm Monitoring Unit at the AIHW. Just before I do, I want to say that having worked in policy for the last decade and a half, I've interacted with a lot of government departments, agencies and teams, and the Suicide and Self-Harm Monitoring Unit is one of the best teams in government that I've encountered. It's an absolute pleasure to interact with people who are so passionate, so knowledgeable, and are listening to the community that their work serves and responding to what they hear by growing what they provide all the time. So it is a real pleasure to introduce our speakers. First up, Chris Killick-Moran, who has a fantastic first name, and he is also the head of the Suicide and Self-Harm Monitoring Unit at the Australian Institute of Health and Welfare. He has more than 20 years' experience in the development of health and policy and evidence in the Australian and ACT governments. His areas of specialisation include suicide prevention policy, mental health policy, alcohol and other drug policy, and the use of data and evidence to inform government decision-making. He holds a Bachelor of Arts honours from the Australian National University. Rosalind Morland is Senior Data Scientist and Project Manager at Suicide and Self-Harm Monitoring Unit. She's been working in the health sector since 2015 as an allied health professional before joining the AIHW in 2017, and her areas of specialisation include biostatistics, epidemiology and public health. She holds a Bachelor of Human Nutrition and a Master of Nutrition and Dietetics from the University of Canberra, is currently completing a Master of Public Health and a Master of Global Health at the University of New South Wales. Like I said, I'm really looking forward to hearing from both of you today. So I'll hand over to you, Chris.
Thanks very much for that introduction, Chris, and really thanks for your perseverance with the acronym AIHW. It's good to see all of that hard work paid off. And I'd also just like to thank you for illustrating the utility of the suicide and self-harm monitoring system in your work. It's one of the things that the team and myself endeavour to do every day, is to make sure that we're including data and information that can inform policy and service responses. To date in this seminar series, we've really focused on administrative data. So the first session, we looked at the mortality data that we have involved in the system. Later in the year, mid-year, we had a look at the morbidity data, particularly the admitted patients, hospitalizations and ambulance data. But one of the things that we know from administrative data is that it cannot answer anywhere near all of the questions that we might have, that we need to have answers to in order to design our policies and our services. And that's why the last seminar for this year, for this series, is focused on research, data linkage and modelling. I'll just start with a very brief example, which we won't be going through today, but as an example of things that we need to look at alternative methodologies to identify. And I suppose a question that's pertinent to all of us in the conversation today is what's happening with the members of our community who identify with LGBTQI plus identities. And quite simply, we can't get access to that data through much of the administrative data at all. And it really kind of makes sense, because I don't really want to disclose my sexual orientation or my gender identity to someone if it's not relevant to the situation at hand. And it's not relevant for the majority of accesses to health services or other supports. So we've been doing some work over the second half of this year with researchers at La Trobe University who have done a community survey of LGBTQI plus identifying people across the country. And that's an example of where we need to take a very specific and measured research approach, or a survey approach, to get to the bottom of some of our important questions. What Ros will be talking you through today, and I promise you this is the beginning and the end of the presentation from my perspective, you'll get Ros's expertise to take you through the data linkage and modelling that we've done over the last year and a half. What we've done is we've linked some of those large administrative data sets with, for example, the census or some other examples of data that we have, so that we can start to get some socio-demographic identifiers into the data set that we don't normally get if we just look strictly at the administrative data by itself. So it's kind of the linkage side of things. But once you are working with large linked data sets and with complex analytical questions, you need to do a bit of modelling on it as well. And Ros will talk you through the basics of that today. I don't want people to be apprehensive. I start every seminar with that, but I have to be honest with everyone, and the content's a little bit more complex today than it has been over the first two seminars of the year. But please persevere, because even if you don't get all of the mathematical or technical details about how things have been arrived at, it's still a useful opportunity to see how you can interpret the results. And that's really what counts at the end of the day. So I'm going to put myself on mute, or no, I'm going to stop talking and hand over to Ros. So please, she's going to present a few models today. And I have to say, these have been some of the most exciting pieces of work that I've worked on in my 20 years in government. So I hope you find it interesting as well.
Thank you, Chris. And just checking everyone can see my screen. Can you see it on your end? Excellent. So good afternoon. Thank you for joining us. My name is Rosalind, and I am the Senior Data Analyst in the Suicide and Self-Harm Monitoring team here at AIHW. And as Chris said, today I'm going to talk you through some concepts of statistical modelling and show you the results of our published models on our website and how they contribute to the modelling system. Okay, so to start with, I'm going to quickly go over what statistical modelling is and why we do it. Now, note, I'm assuming no prior knowledge to modelling, and I'm going to do my best to keep it relatively simple. As Chris said, persevere, and there'll be chances for questions at the end. But I'm going to try and make it as simplistic and relatable as possible. So statistical modelling uses clever maths and statistical assumptions to estimate the effect of an exposure on an outcome in the real world. So, for example, exploring the relationship between, say, education levels as the exposure and suicide risk as the outcome. Now, why do we model? Well, modelling, as Chris touched on, helps us answer those causal questions. That is the exposure associated with the outcome? So exploring causal inference may be done usually through randomized controlled trials, but sometimes it's not ethical or feasible to run those trials. So, for example, it wouldn't be ethical or feasible to randomize a study participant to a certain education level and see if it affects their risk of suicide. Trials are also very expensive and difficult to run. So this is where modelling can be really helpful and powerful because it has those implications for policy and funding decisions. So how do we do modelling? A good method for modelling, as Chris touched on this as well, is using real-world administrative data that is often linked to other data sets, such as census data linked to deaths registration data. And this is sometimes called big data. It enables us to create large study populations to maximise the precision of our estimates, and it also enables us to emulate that trial. So, for example, we can create comparison groups, such as comparing people's education levels and exploring the relationship of those groups on death by suicide. Okay, so most data on the AIHW website is descriptive. This means we are just looking at what's happening in these data, reporting numbers, proportions, and rates, and not making any inferences about these data and what caused the outcome. Descriptive analysis is really important for monitoring and getting a sense of what's going on, and we've explored these data in our previous webinars. However, we do have some statistical models published on our website, and the models I'm presenting today use linked data from the Multi-Agency Data Integration Project, or MADIP for short. The MADIP is a data asset linking administrative data such as death registrations and the Australian Census of Population and Housing. I've also provided links to the technical notes down the bottom here if you want to get a bit more information on the MADIP. So just before I dive into the first model, I just wanted to provide a little bit of a warning. I'm going to be describing risk factors for suicide, and sometimes these risk factors may feel a bit more personal, or you may know someone with those risk factors. If you feel distressed at any point, please stop listening and seek help right away. There's a crisis support page on our website, or just Google Lifeline or suicide crisis support. And please, I encourage you to take time to look after yourselves after this presentation also. Okay, so the first analysis I'm going to show you today explores education levels and employment status as risk factors for suicide. This was one of the first models we did, and it answers the question, was educational attainment and employment associated with suicide risk in Australia, in Australians aged 25 to 64 years between 2011 and 2017. So this analysis reports age-adjusted cumulative incidence, percent, and rate ratios, which I'm going to talk you through. So the age-adjusted cumulative incidence is calculated by taking the number of cases or deaths by suicide within the study period, which is 2011 to 2017, and dividing it by the total number of people at risk in the same period, so the Australian population within that period. And then it's adjusted for age. These two diagrams below, it's just a little bit of a visual representation of what we're looking at here. So we're just looking at the relationship between level of educational attainment as the exposure and death by suicide as the outcome, and same for employment status as an exposure as well. So I'm going to try and be clever here and stop sharing and hop over to the website. So just bear with me while I do that. This is going to work. Great. And I'll just put this up here. Okay, hopefully you can all see my screen. So these are our published results of that first study. And what we can see here in this visualization is that the estimated suicide risk, which is measured by that age-adjusted cumulative risk, but from here on out, I'm just going to call it risk because that's a very long way to say it. It's higher, that risk is higher among those with fewer years of education. Sorry, I'll just hop over to education. There we go. Yeah, so we can see the suicide risk is higher among those in particular who have secondary school or lower for both males and females. Now, just to explain a few more things before hopping into the results, we also have this table down here presenting rate ratios. And what we have here, this first group, we're looking at those with educational attainment year 12 and below, and we're comparing that to the second group, people with a bachelor degree and higher. And so we're just comparing the risk of this group compared to that group, which is just this risk divided by that risk. And that gives us in males, a rate ratio of 2.6. And what that means is that the risk of suicide among males with education of year 12 and below was 2.6 times higher than those with a bachelor degree and higher. So when I'm talking about rate ratios, we're comparing a rate to another group. So I'm going to hop back up here and just go through some key findings. So yeah, we just saw a 2.6 times higher risk in males and we can see that here between secondary school and bachelor degree or higher. And in females, this difference is 1.6 times higher risk of suicide in those with secondary school or lower education. And we can also see that the estimated suicide risk is higher among males across all levels of educational attainment. And among males with only secondary school or lower, the risk is 3.5 times higher than females with secondary school or lower. So I'm just going to hop over to labour. So that's a pretty clear relationship between education and suicide. And I should also note, we're not adjusting for anything else in this model. We're just looking at the straight relationship between education and suicide and employment and suicide. But we are, in the next model, you'll see what effect adjusting for other variables has. So for labour force, suicide risk is 3.2 times higher among males who are employed than those who are not in the labour force. And people who are not in the labour force, just note, they are people who are neither working nor looking for work. And for males who are unemployed, the risk is 2.5 times higher than males who were employed. And for males who were not in the labour force, compared to unemployed, the risk is a little bit higher. It's 1.3 times higher, or 30% increased risk. And this is just as important, is that when we're thinking about labour force status and suicide, that we can't just focus on the unemployed, that we also need to consider the group of people who are not in the labour force for whatever reason. So we can't just talk about the unemployed. Now, for females, we can see the risk is much lower again, but there is still quite a big difference, a 2.6 times higher risk of those who are not in the labour force compared to employed. But I will point out that is quite a big difference. But when you're looking at rate ratios, so those numbers I was just quoting, they're from this table. it's really important to look at them together with the absolute values. And what I mean by absolute values is that straight age-adjusted cumulative risk. Because the rate ratios are really useful for interpretation. We can say, okay, the difference between that group and that group, this group was 2.6 times higher than that group. That sounds like a big number. But you need to take that in addition to those absolute values, because the absolute values are actually more useful for public health policies and decisions, because that's a 2.6 times risk, but overall, the risk in males is so much higher than females. So if we get stuck on just comparing rate ratios, you'll miss a big part of the story. So you just need to remember to always look at those things together and never on their own. Okay, now I'm going to hop back to my presentation. So bear with me while I share my screen again. It is this one. Those were just my backup slides in case the website was down, which it never is. It's just in case. Okay, so the next model I'm going to run through is a little bit more of a complex model. We call it our regression risk model for selected census variables. And what we're looking at here is social factors and death by suicide. So why are we looking at social factors? Well, social factors like education and employment status, like we just saw, but also income level and wealth, those things all play an important role in determining the risk of suicide in high-income countries. Suicide is a complex interplay of a combination of factors. However, some social factors may be associated with an increased risk. And understanding the relationship between those factors and the risk of suicide is really important to inform strategies and services to reduce suicide. So this model that we see here on the right is a regression model, which is a predictive modeling technique used to investigate the relationship between the outcome, which is death by suicide, and an exposure, which is any of those risk factors in that table. For easier interpretation, we use hazard ratios. And what that means is that the risk of experiencing an event within a time period, so the risk of dying by suicide within that time period, which is the hazard rate, compared to a reference group. And that's where the ratio comes from. So just to talk you through that a little bit more, let's look at males here, this blue dot over here. So the suicide risk in males is about 3 times higher than the reference group, which is females. Okay, so females sit at a hazard ratio of 1, while males sit at a hazard ratio of 3. And that just means males are always 3 times higher than females. This dotted line down here represents the line of no difference. So if you have a dot or a bar that is overlapping that line of no difference, what we're saying there is that compared to the reference group, there isn't an increased risk of suicide. If your dot is on the left-hand side of the line of no difference, that means you have a decreased risk of suicide. If it's on the right-hand side, which a lot of the dots are, that means you have an increased risk. So I hope that's clear, but we are going to talk through those results a little bit more. And just to note that this line here on either side of the little square dots, that's our 95% confidence interval. And what that means is that we're 95% sure that the true estimate lies somewhere within that range. So if those bars are overlapping, like they are here in labour force participation, unemployed and not in labour force down here, they're overlapping. So that's just basically saying that there's not a significant difference in suicide risk in those groups. compared to employed as the reference group. But some of them are quite different. So lone person, single parents, they are quite different compared to the reference group. That's just a little bit of interpretation. I'm going to move on though. Another little note for interpretation is this method uses proportional hazards. And just to simplify that, that hazard rate ratio, so as the black line increases or decreases, the dotted line increases and decreases proportionally with it. So at any point, this dotted line, at any point in time, this dotted line is 3.7 times more than that black line. And it doesn't matter how much that black line changes, this dotted line is always 3.7 times higher. And that's when I was talking about the difference between males and females. At any point in time, the risk among suicide for males is estimated to be 3 times higher than females. So that's enough of exploding brains. I'm going to get into the results now, but there is still a bit more of brain explosions. So just a heads up. Yeah, so when it comes to regression modeling, we are trying to build the best model to predict an outcome. We never know if it's truly the right model, and we'll never know what the true hazard ratios are. We can only produce our best estimates. So that's something to keep in mind about modeling. It's an estimate. Unlike our descriptive data, when we're looking at the straight data, we're saying, okay, that's what it actually is. So to do that, to create the best model, we've included a few different models on our website. We've got a multivariate model, a univariate, a male stratified, and a female stratified model. A univariate model means we are looking at just one exposure compared to the outcome. So the previous models we looked at before with education and employment, they were univariate models. We aren't adjusting for anything. We're just looking at the straight relationship between these two variables. So the example I've got up here in the model we're looking at for Indigenous status, the risk of suicide among Indigenous Australians is 2 times higher than non-Indigenous. Non-Indigenous is the reference group here. And that's when we're just looking at the straight relationship. But when we hop over to the multivariate model is we're looking at multiple exposure variables all at once, and we're adjusting those results for all the other variables in the model. So when we look at Indigenous status, the risk of suicide attenuates or decreases from 2 times higher down to 1.3 times higher. So instead of 200% increased risk, it's now a 30% increased risk. That's a 74% reduction in the difference of suicide risk between the two models. And why we're seeing that is because we're accounting for all the other variables in the model, which means that 74% of that reduction, the relationship between Indigenous status and dying by suicide is explained by the other factors in the model. So just to break that down a bit more, we're looking at Indigenous status and suicide. And then there's these other factors like education, and employment, which we just saw does increase the risk of suicide. That's a risk factor for suicide, but lower education and unemployment may also be associated with Indigenous status. So it's amplifying the effect of Indigenous status on suicide, and that's called confounding. And this is really useful information for policies, because if we can address those confounding risk factors in Indigenous people, we know it would have an effect on suicide risk. So that was a little bit, that was a lot to take in, but all you really have to take away from that is that there are other variables in the model like education, employment, family household. It's not the fact that you're Indigenous that means you have an increased risk of suicide. It's all the other factors that are associated with Indigenous status that are increasing the risk, which we can modify. Okay, so sometimes in regression modeling, it's useful to look at data in distinct groups. And for this is especially the case for sex, for males and females. It's because sometimes sex happens to exert an effect on the relationship between a social factor and death by suicide. And what I mean by that is that the effect between a risk factor and suicide is not the same in males as it is for females. So an example is that male single parents had a 1.3 times higher risk of death by suicide compared to males in a couple without children. So there it is there. But we didn't see any difference in females in that same risk factor. And same for females. Females who needed help with core activities of daily living had a 2.4 times higher risk of death by suicide compared to females who did not need help. But for males, there was no significant difference. So that's why sometimes it can be really helpful to stratify by sex, so that you can look at those differences. And the other point is sometimes you do just want to focus on males, or you do just want to focus on females. Here are some more key findings. They're on the slide, so I'm not going to go through them one by one. But I will hop over to the model just here in the PowerPoint. Oh, sorry, I'm on the website. So just give me 1 second and I will share my screen again. Hop over very, very quickly. Here it is. When you have a moment, please check out our regression risk models for selected census variables. It's very interesting. You can swap between the multivariate and univariate here. So if I hop to the univariate, we can see that a lot of these risks are much higher. And then when I hop to multivariate, when we actually adjust for all the risks in the model, a lot of those risks decrease. Again, that just means that a lot of these risk factors we can actually do something about if we can modify them and we can reduce risk of suicide. The only one we haven't been able to explain here is males. In the multivariate model, the risk of suicide is still 3 times higher, even after adjusting for all these other things in the model. And what that's telling us is that there's bits missing from the model. Like I said, we're just trying to make the best model we can with the data we have. But there would be some unmeasured confounders that are influencing that relationship between being male and suicide that aren't in this model. So there is more work to be done. I'll share my screen again, back to the PowerPoint. I wish there was an easier way to jump back and forth. Probably is. There we go. All right, I'm going to keep moving on. So the last model I'm going to show you today is, it builds on the previous model we just saw, but it includes some additional income variables developed by our friends at the ANU. So this is part of that commissioned research side of things. So this model aims to explore the relationship between income variability, and other social factors with suicide risk. And it also looks at those social risks social risk factors after adjusting for income and income variability. Okay, I'm going to pop back to the website. Hang on. It's just better to give you guys a live demo. Okay, so here is the income model. So this first visualization, we have 5 groups of income. the income quintiles. So the first group, you're looking at income between $0 to $15,000 a year. The band is much larger in the highest income group. And within each of those groups, you have your income variability or income uncertainty. And what we mean about income uncertainty is you just might not be getting income consistently for whatever reason. So you just might not know when your next pay is coming, or you run a small business and it fluctuates. There could be many reasons why your income would vary. But what we can see straight off the bat, that the lowest income group has the highest probability of suicide. And this is after adjusting for all the social factors. And within that group, the highest income uncertainty, so that's where your income varies quite a lot, has the highest probability of suicide. And we can see across all groups that income variability does increase suicide probability as well, but it is most pronounced in this group here. So just moving down to the regression model, it's similar to our last model. The dotted line here, it represents the line of no difference. If it crosses that line like this one does, it's unlikely there's an increased risk of suicide. But the difference in this model is that we've thrown in income uncertainty. So we can see with increasing levels of income uncertainty, there's increasing risk of suicide. With increasing levels of income, there is decreasing risk of suicide. With increasing years of continuous unemployment, so the longer you are unemployed, your risk of suicide also increases. But there isn't a big difference between these groups. We can see that those error bars overlap. And then there's the familiar social risk factors that we looked at earlier. So again, I encourage you to go have a look, give the text a read as well. There's some really good findings in there. This one is also stratified by males and females, so you can look at them on their own. And it's also stratified by people who had increases in their income and people who had decreases in their income. So I'm just going to hop back to the PowerPoint now. So what's next for our modelling journey? Well, we are planning to do a regression analysis on health service use in last year of life. A few weeks ago, we put out a descriptive analysis on this, and that was using the linked data asset, the National Integrated Health Services Information Analysis Asset, or NICI for short, and that links hospitals data, emergency department, deaths, MBS and PBS data. So it's a huge data asset. And I'll take you through a few of those results in a moment. But we only did descriptives, and we'd like to do a regression analysis like we've done with the MADP. I haven't started any work on that, so please don't say that this is nothing to do with anything apart from just an example of what we've learned today in modelling. But for example, we could look at health service usage from the NICI and the intensity of someone's health service usage as the exposure, and see what relationship that has with suicide as the outcome, while adjusting for other demographic or other health service usage variables. For example, again, haven't started. So, so here's just some key findings from that descriptive analysis. I'll show you where it is on the website too. But what we found was that almost half, so 49% of 15 to 64-year-olds who died by suicide did not have any contact with the hospital. So that's emergency department or hospital separation. And those results are similar to the results of a similar study by Angela Clapperton in 2001. who found that 50% of people who died by suicide in Victoria did not have any ED or hospital separations in their last year of life, and that was using Victorian suicide registered data and included all age groups. So we're pretty bang on. Over 1 in 10 people, or 11%, aged 15 to 64 who died by suicide did not access any health services in their last year of life. So that could be MBS, PBS, hospital, ED, any of those. And of those who died by suicide, the highest proportion of hospital contacts occurred 1 month prior to death, and that's out of 12 months. So out of the 12 months that they were accessing health services, the highest proportion occurred the month before death, which might indicate an increased risk following the use of some services, which is why we want to do a regression model. So again, I'm just going to quickly hop to the website, and it's the last time I'm doing that swap. So just bear with me. Can you see that on your end? Yep, sweet. Wasn't sure if I hit the button correctly. So here's our brand new hot off the presses publication on patterns of health services in last year of life. We're running a bit short of time, so I'm not going to spend too much time on it. And it's descriptive, not modeling, and the Tableau has decided to not load, which is why I have backup slides. There we go. There we go. So this visualization, for example, we're comparing two groups. We've got people who died by suicide and people who died by other causes. And then we have age groups within that. And what we're looking at here, I've got it filtered by people who did not have a service. And we've selected any hospitalization that includes ED, but you can select a number of different services and have a look at how they compare. And we can see here that those who died by suicide tended to have a higher proportion of not having a service across all age groups for any hospitalization. And just for interpretation, in this visualization, to make up 100%, so we've got 51.6% in this age group did not have a service. If I swap to did have a service, Tableau's a little slow today. All right, Tableau's not really behaving, but oh, there we go. The remaining 48.4% is in did have a service. So there's a little note there that those two add up to 100%. So it's not this and that adding up to 100%. It's did have a service and did not having a service adding up. I will show you one more visualization and then we'll call it a day. This visualization, again, we're looking at two groups, people who died by suicide, people who died by other causes. And we're looking at any hospitalization, but you can look at a different service if you wish. And this time I'm looking at the proportion of people who had that service. So this is all people who did have a service. And what we can see is that the proportion of people who had a hospitalization is higher in those who died by suicide compared to other causes, up till about the age of 45 to 54, where other causes take over. And that's what we expect to see. That's consistent with the leading causes of death, where the leading cause of death in people aged 15 to 44 is suicide. And then above the age of 45, people start dying of other things like chronic diseases. I think that's it for now, so I'm going to stop sharing. And Chris, is there anything you'd like to add?
Thanks, Roz. There's nothing I'd like to add at the moment. I've been addressing most of the questions as they've been coming through on the text line. There's one that I can never remember the answer to. Ghazala Adam has asked, does the NICE AA have data from all states? And I can never remember who's in and who's out. And there's the version 0.5 and the, yeah.
Yes. Well, I'll have to remember the states too. No, to answer your question, no, it does not have all the states. We used version 0.05 because that's the version that was available when we were doing the analysis. And that version, just trying to see if it's here. Trying to see if it's on the webpage so I can get you the exact states. Yep, okay. So it has all states for MBS and PBS, but not the hospital's data. The hospital's data is limited to only New South Wales, Victoria, South Australia, and Tasmania. So I'll say that again, New South Wales, Victoria, South Australia, and Tasmania. So because of that, and this is a really good question actually, we've restricted that analysis to those states and territories. So we're not comparing national suicides to those states to national. We've restricted it to all just those jurisdictions. In version 1, which we'll do the regression model on, is the updated version. It includes Queensland, so it's a bit more representative. That's a really good question. But it's all on the website, so have a look there. There's technical notes. Yeah.
Excellent, thanks. We've just got a question here from Tan Nguyen as well from DHHS. Will the data soon capture all health services, not just hospitalizations? So I can have a quick stab at that, Tan. At the moment, the models contain the hospitalizations, admitted patients' hospitalizations data from the jurisdictions that Ros just mentioned. It also includes all pharmaceutical benefits scheme claims and all Medicare benefit scheme claims. In terms of services in the community that will be funded through states and territories, we don't have access to that data at the moment, and we're in conversations with a few jurisdictions who do have good quality data in those areas to see if we can rerun this analysis, including state and territory funded community-based services. What we will not be able to get a handle on at the moment is NGO services that are not directly funded by the Commonwealth or the state or territory. And so that's kind of your NGOs funded through perhaps PHNs or that kind of arrangement. And we won't be able to get access to private hospitalizations data or private healthcare. So for example, if people are paying for a psychologist out of their own pocket or something, we have no way of capturing that.
Chris and Ros, it's Chris Stone here. We've got some other questions coming through other streams, if that's okay.
Yeah.
So we've had some questions around suicide first aid training. And the question is there any research in the system to date or planned on building community capacity for suicide prevention?
I'll take that as well. Thanks, Chris. No, at the moment we are focused on service use as we've described through the medical system. We don't have good data on suicide prevention activities. It's something that people have asked us in the past, but we just don't have access to the input data, I'm afraid. So we haven't been able to look at those things. I suppose one other important distinction is that the AIHW doesn't strictly perform service evaluation type analyses, and so we wouldn't do things along that line.
If I could just add on to what Chris is saying, I think it's important to keep in mind a lot of the analysis we do is on administrative data, and it's secondary analysis of that data. So those data sets like hospitals and deaths, they weren't created with us in mind, saying, oh, Chris and Ros are going to do some work, so we better collect these variables. They are used for administrative purposes, and we just do what we can with that secondary analysis. But yeah, if it's not recorded, or if there is no touch point with those systems, then we can't see it, unfortunately.
Yeah, understood. Thank you for that answer. Another question that we've had come through says, today's models have focused on suicide deaths. Has there been any similar research on other suicidal behaviours such as attempts or intentional self-harm?
That's an excellent question with a very complicated and quite unsatisfactory answer, I'm afraid. So With the hospitalisations data that we have in the model here, that is for intentional self-harm hospitalisations. The coding is blind to whether the intent of that self-harm was to die by suicide or if the intent of that self-harm was for some non-suicidal purpose. So unfortunately, we can't disaggregate those behaviours in the hospitalisations data. We do have that distinction available to us in the ambulance data that we collect through our collaboration with Turning Point in Victoria. And so over time, we should be able to link some of that ambulance data to some of the data sets that Ros has been describing today, and that will give us a proxy for what the purpose of that admission was. But for non-fatal suicidal behaviours or non-suicidal self-harm behaviours that do not result in a touch point with the system. So, for example, well, someone doesn't go to see a hospital or another service. We don't have any data on that at all, unfortunately. This is an example of where I started the discussion today by referring to the community survey that La Trobe had done in the LGBTQI+ community. It's really only through survey instruments like that that we can approximate those self-harming and suicidal behaviours that don't result in a touch point. And that opens up a whole different set of analytical problems in that the survey data provides estimates. You can't link survey data to other things because it's not actually representing an individual person. It's representing an estimate at a population level. So we do run into a lot of analytical trouble looking at those behaviours, but we're hoping we can get some way by looking at where we can link the ambulance data.
Thanks for that. That's great. Great to hear. To everybody out there in this webinar, we have got a couple more questions queued up for Chris and Ros, but we've allowed a fair bit of time for questions, so please feel free to throw your questions in the chat. Chris and Ros, the next question I've got up is that it says, we saw in the first webinar how valuable near real-time monthly data on suicides from New South Wales and Victoria is. Is there any progress to report on the other states and territories providing monthly suicide data in the monitoring system?
Absolutely. That question brings me so much pleasure on so many levels. One, because it means that someone remembered what we did earlier in the year, which is always nice. But we do have progress to report to the group. So we are now in a position in Australia where we have suicide registers established in every jurisdiction with the exception of Western Australia. And Western Australia is a slightly unusual circumstance because of the way that their coronial legislation is drafted and is being interpreted. But we are in conversations with our colleagues in Western Australia. So we are now in receipt of data at different levels of timing from Queensland, ACT, Victoria, South Australia, and Tasmania. Our Northern Territory colleagues have just stood their system up, and so we're expecting to start getting data feeds from them probably early in 2023, I would hope. And in other important developments, we've started conversations with coroner's court, well, sorry, not coroner's courts, registers, because not all registers sit in the coroner's court, I should clarify, to establish a network of technical practice around the country so that those suicide registers can both learn from each other in terms of application of technical questions to how they capture the data or code it or how they interpret particular evidence, to try and seek a level of consistency between jurisdictions where that's feasible. But it also establishes a bit of a research network where we can get together with the registers and unpick some of the questions that Ros and I have indicated we're not able to answer through some of the administrative data we have. And we know that the suicide registers do capture data, for example, on ADF employment status, LGBTQI+ identification status, sometimes around cultural and linguistic diversity, which was a question that came up in the chat line earlier. And so we'll be able to use that network to start doing some really interesting research, I think, that can only be done through that mechanism. The other benefit of that network is it's not just a matter of the jurisdictions collecting the suicide data in their registers, it's how is that data disseminated to state and territory authorities who can actually provide some level of intervention or support within an affected community. And so we're working with the jurisdictions to see how the holders of that data can best make it available to people in the mental health, hospitals, ambulances, police, education officials who can actually get into the communities and provide that additional support using that real-time data so that we can actually get into those communities quite quickly. Just finally, because I know we're running out of time, but we're doing some work with some of the jurisdictional registers and the University of Melbourne looking at statistical techniques for analysing unusual patterns within the data. So, for example, do we have a spatio-temporal clustering of deaths in an area which is statistically higher than we would expect given the historical trend in that area? And that might mean that something particular is happening with a group there. Or is there an age-sex cohort within the jurisdiction that are exhibiting different levels of death by suicide than we might anticipate? And people who have been following the New South Wales and Victorian publications closely, there are some numbers coming out in the 65 plus male cohort over those two jurisdictions in the last few months that is starting to cause some concern. We wouldn't have the ability to do that without these registers. So yeah, we've actually made some really good progress over this year. So thank you for asking the question.
Thanks for that, Chris. Just got another question popped up in the chat. Not sure if you saw that one. Is it possible to have some understanding on who is able to access or not access suicide services and support from the data that you have?
That's from Catalina. No, we can't see who's accessing suicide support services, I'm afraid. No, majority of those services tend to be funded through NGOs and that sector. So we don't, unfortunately, we don't have access to that.
Thanks, Chris. And I've got one final question lined up, and this is a last call for people to put questions through until we close the survey. But it was great to see that there was that a great deal of the higher risk for Aboriginal and Torres Strait Islander people could be reduced by addressing other factors. Am I correct that this is an indication that if we close the gap, we can save lives?
Absolutely. And further than that, it indicates that by that relatively short list of quite modifiable factors, we were able to explain about 70% of the variation between the Indigenous population and the non-Indigenous population. So addressing those causes or those sources of relative disadvantage, you can actually close the gap.
Yeah, great. I've just, sorry, one more question has come through. You mentioned further modelling on service usage in last year of life. Are there any future priorities of research for next year?
All of them.
Yeah, I'm going to say that's what we call a whiteboard question. I should show people the whiteboard in my office. It's absolutely covered with stuff that we want to do. I'm currently going through a technical assessment and ethics application to link the deaths index with homelessness support services and alcohol, tobacco and other drug specialist treatment services so that we can get a sense of what's happening through some of those community supports. There's one linkage that we're looking at doing at the moment that we've got going. Ros has already mentioned some of the work that she's looking at doing the regression around the NICI material. If people weren't following the chat because they were so engrossed in Ros's presentation, which would be perfectly understandable, there was a question from one of our colleagues around culturally and linguistically diverse populations, and we've got some discussions ongoing at the moment about linking to the Department of Home Affairs immigration database and being able to use that to track people who come through various migration and refugee cohorts. So yeah, we've got a pretty full dance card. I'm sure we'll be having a similar discussion with a lot of new exciting analyses this time next year.
Well, thank you for that. So I'm just turning my camera back on to round off the end of the webinar. But thank you both, Chris and Ros. That was fascinating. A lot of the results that you put there were really interesting. Was really interesting to see stratifying by gender. What that means that when we're approaching services for either women or for men, that we do have to be paying attention to different potential risks. So that was really good to see, along with everything else. Also big thanks to everyone out there who's turned up for this webinar. It's really great to see the turnout that we had, and thank you for the questions that you sent through. Some really great questions that explored some of the further issues. I will note that in future we will be making a recording of Ros's presentation and of the previous 2 webinars, so keep an eye out for that. But yeah, just finally, thank you very much to Chris and Ros. As I mentioned before, if you had a question that you was not answered, or you think of a question later, please email Suicide Prevention Australia and we'll endeavour to answer it. And a final reminder, if you need to, please reach out to a trusted friend, colleague, or one of the support numbers we've listed if you feel that you need additional support. So look, that's it for our webinar, everyone. I hope you enjoyed it as much as I did. Have a great rest of your day. See you later.
Thank you.